So I do have a review article in NEJM with one of my co-surgeons in neurosurgery, Dr. Michael Link, and I think it provides a great overview in a short amount of text about the topic of sporadic vestibular schwannomas. It's up to date. It talks a lot about emerging therapies, how how patients present, the indications for getting scans, the relevant anatomy, and an overview of treatment. That review article will overlap quite a bit with the other 3 talks or 4 talks in this series. If you're very interested, I know it's very hard to have an interest develop this early within neurosurgery, but if you are very interested in skull-based surgery, or if you somehow have seen the light and you're very interested in it, let me know. I have some extra copies of this book. I don't have a ton of them, but I'm happy to send them out for free. It's like a $200 book. Otherwise, they're collecting dust on my shelf. But it's a 500-page book, and I think, at least in my opinion, it's the most comprehensive book on vestibular schwannoma available right now. It covers all facets of the disease pretty well. I work in what I would consider, one of the best things I ever did, I think, was, pick my partners that I work with, both in ENT and in neurosurgery. That Dr. Driscoll and Dr. Neff are my 2 colleagues in neurotology, and Dr. Link and Dr. Van Guppel, and now Dr. Paracelda, who's joined us, who spent some time in Dr. Roten's lab, was recently in Albany. She's joined us too. And I think a lot of the success of any one of us individuals is largely because of the team we work in. I'm very interested in the history of surgery and medicine, and specifically skull-based surgery and ear surgery. And so I looked back in our archives at the Mayo Clinic to see when the first vestibular schwannoma surgery was performed that I could find. That was in 1907. We have a longstanding history of treating people with microsurgery, but also radiosurgery. We had the 3rd gamma knife unit installed in the United States. We have a very strong collaboration between otolaryngology and neurosurgery. We basically see all of our patients jointly in a combined clinic where neurosurgery comes to the ENT floor, and we talk about the scan, visit with the patient, and come up with a collective plan. You'll see when you are in residency and in practice, one of the things that frustrates a patient significantly is getting mixed messages from the same team. They'll visit with one surgeon, and they'll go to another area and visit with somebody else, and you'll give a little conflicting thoughts. And from a patient's perspective, you could see why that's very troublesome. 2 experts under the same roof are giving different opinions about something. And that's why we do this together. We meet together ahead of time and then visit with the patient, and based on their priorities and what we can see, we come up with a shared decision-making plan with the patient and us. We see about 200 patients a year. This is a pretty interesting operative note. I archived a lot of these old operative notes. That's Adson. Like if you use the Adson Brown, Adson was the chair of neurosurgery at Mayo Clinic. If you don't call Charlie Mayo the first chair of neurosurgery, Charlie Mayo was involved in neurosurgery, but Adson was the first separate chair. That's the same Adson forceps that you probably are familiar with in the operating room. And Adson and Brown was a plastic surgeon at Mayo Clinic, so like the Adson Brown pickup, for example. But this gives an interesting history. It tells how far we've come, and probably, I suspect in 100 years, people look back and laugh at our operative notes. But this was basically a patient that they were doing a CPA tumor, probably a vestibular schwannoma on. They got frustrated because the patient couldn't sit still. So the patient was basically awake, probably with a slow ether drip. But it was largely under local anesthetic. So we're going to talk about pathophysiology, epidemiology, the diagnostic process, natural history. We'll touch on some other aspects too. I basically could probably talk for 24 hours straight on this. And so I suspect we won't get through it all, but I'll go through some things that I think are interesting. I think a lot of the things you read in textbooks are very old, outdated, and they don't give you the full breadth of knowledge, particularly a lot of the textbooks that summarize things, like the short, I'm not sure, I can't remember the name, Goldberg or something that you guys have in neurosurgery. Those are great for learning neurosurgery in a nutshell, but they don't give an expanded depth of knowledge, and they oversimplify things. And so this talk may be in some ways a little more confusing because you might have read a couple statements that I'll probably debunk in this talk, but I think it's a good segue into the next talks, and you'll see that it's not so simple. So pathophysiology, are there risk factors for sporadic vestibular schwannoma? So 95% of vestibular schwannomas on the earth are sporadic, meaning they're not associated with neurofibromatosis type 2. They're not heritable. There's this old belief that there's such thing as a familial unilateral periganglioma syndrome. And that was because there were a couple family members that had a unilateral tumor, and they said, well, these are so rare, the chance of that happening is basically impossible. And so there must be a possibility of a different gene or different disease phenotype that could result in unilateral vestibular schwannoma. But it turns out that really, when you overlay these with epidemiological studies, you can see that it actually is possible on a population level to have a couple patients in the same family have them, and there is probably no genetic predisposition to unilateral isolated vestibular schwannoma, despite what you may read. There's also some thought that maybe cell phones predispose people to it. The idea is that the constant low level of radiation or exposure that you might get from having a cell phone on an ear might predispose you to it. And the idea is that people who use cell phones have an increased risk. There's some epidemiological data that says that. I think that, so the jury's still out on that, but I think most people think that a cell phone is the perfect screening tool. In most situations, if you have a little bit of hearing loss, which is the most common presenting symptom for a vestibular schwannoma, if you just when you're walking around, you don't notice a little bit of hearing loss in one ear. When you're laying down at night and you put your good ear on the pillow and your bad ear is the only one you're listening with, you'll notice it a little bit more. Or if you put a cell phone up to your ear, it's the perfect screen. If the volume on your cell phone is a little bit low, you'll say, I can't hear very well. What's going on? And then you'll say, I have hearing loss. And that'll lead to an audiogram or hearing test. And then that will lead to an MRI, and that will lead to a diagnosis. And so people think cell phones cause vestibular schwannomas. I don't think that's true. I think they're the perfect screening tool to find a vestibular schwannoma. That's my opinion on it. There's a couple scatter papers that will say allergies or even smoking cause vestibular schwannomas. I'd say that's probably not true to the best of our knowledge. The only really known environmental, or the only risk factor we know for sporadic vestibular schwannoma is history of ionizing radiation. In the 1940s, 50s with World War II and the atomic bomb, there are groups that had fallout radiation that developed vestibular schwannomas, meningiomas, thyroid tumors, all these other things later. And vestibular schwannomas were in that group of tumors that were developed as a cause from radiation. There's also the tinea capitis group, or people that got low dose radiation for tinea capitis or adenitis, things like that at a young age that developed vestibular schwannomas and other tumors later. But that's a small group. So most people have no known risk factor. So why do they develop on the eighth nerve? Why are vestibular schwannomas, also called acoustic neuromas, two names for the same thing, why do they develop on the eighth nerve? Why don't they develop on the fifth nerve? If you look at the fifth nerve in somebody's head, it's a much bigger nerve. So why wouldn't it develop there? Or why wouldn't it develop on one of the longer nerves, like the fourth nerve? It's a longer nerve, so wouldn't there be a greater probability of developing a tumor if you had more surface area? We don't know for sure, but there's some theories. The first is it has a very significant Schwann cell density. So the idea is that the more Schwann cells you have, the greater probability you'll develop a schwannoma there, just by statistically speaking. The other idea is that Scarpa's ganglion, which is your vestibular ganglion, is associated with an increased risk also related to Schwann cell density. And there's some thought that there's something specific about the PNS-CNS junction. We don't really know for sure. They typically will develop around the porus. They can develop at the fundus. So if you think about the anatomy of the internal auditory canal, when you have the cerebellopontine angle, it opens into the temporal bone through the porus acousticus, which is the medial opening of the internal auditory canal. And then the length of the internal auditory canal on average is about 1 centimeter. It could be 0.8 centimeters or 1.2 centimeters, but it's right in that range. Then the other end of it, before it enters the actual bone of the temporal bone, it's called the fundus. So most tumors develop around the porus. They can develop at the fundus, but it's very rare that they actually develop in the angle primarily. That does happen, but it's more common in F2, neurofibromatosis type 2. So these are just the different nerves, and it's interesting that there is a predilection for the eighth cranial nerve compared to all the other nerves that they could develop on. There's another condition, we talked about NF2. There's another condition called schwannomatosis. And there are very developed criteria for the clinical diagnosis of NF2 and the clinical diagnosis of schwannomatosis. But if you really distill them down, NF2, most commonly, about 90% of people with NF2 have bilateral vestibular schwannomas, and they may have other schwannomas, other cranial or spinal or peripheral schwannomas. They'll often have spinal ependymomas, meningiomas, and there's a smattering of other less common things. Schwannomatosis typically involves multiple peripheral, spinal and peripheral schwannomas in no more than one unilateral vestibular schwannoma, so no more than a unilateral vestibular schwannoma. There's more details in the clinical diagnostic criteria, but as a general rule of thumb, that's how you can distinguish them all. It turns out that the money's on the NF2 gene for the development of a sporadic vestibular schwannoma. So the putative or the causative gene mutation or variant in patients with neurofibromatosis type 2 is a mutation in the NF2 gene. The difference between someone with NF2 and somebody with a sporadic vestibular schwannoma is whether or not they have a mutation in their somatic cell line. So all the tumors have mutations in the NF2 gene in the cells in the tumor, but if you have a mutation in the NF2 gene in other parts of your body, then that constitutes neurofibromatosis type 2, at least from a genetic standpoint. There's all these different variants. I'm sure in medical school you've heard of mosaics. So at some time after fertilization, at some point when the cells were dividing, you acquire a mutation at the 4th cell or the 8th cell or the whatever 100th cell division. And so you can get certain areas of the body that can preferentially develop schwannomas. So it's a mosaic. Those are typically less severe phenotypes for NF2. And then constitutional NF2 is where the whole body has a predilection for development of tumors associated with NF2. Backing up to the sporadic group, it's the tumor, the mutation in the NF2 gene is isolated to the tumor itself. It turns out that if you strangle the DNA enough, you'll find out that there are 2 variants in basically, we think, in every single tumor. There's a double hit in every single vestibular schwannoma. The old data will say it's only present in one of the chromosome 22s in 30% of people, but the better the sequencing that you're using or the more deep sequencing you're doing, you'll find more and more hits. And recently we published a paper showing that you could find a double hit in every tumor. I think we had 23 or 24 tumors in this. I'm going to talk about a couple of things you'll read in textbooks that aren't true. So epidemiology, how common are these? So if you, when you're on your clinical rotations, your provider, the person you're with is going to say, well, a patient comes in, they say, how common are these? The surgeon's going to say, well, it's 1 in 100,000. You won the bad luck Powerball or something like that. But I'd say it's more like winning the bad luck scratch off. Your luck's not that bad, but it's, they're not that rare. They're uncommon, but I wouldn't call them rare. So the old way to say it is there's a 1 in 100,000 people develop these, but you got to separate prevalence and incidence. If you think what you learned about epidemiology, incidence is the number of new cases per population per time. So it's typically new events per population per year. It's a common way of talking about incidence. Prevalence is not new cases. It's anybody in the population at that time that have the condition. So people that were diagnosed 20 years ago could be included in prevalence, but they wouldn't be included in incidence. And that's important because most people don't die of vestibular schwannomas, and a lot of people have them observed or have radiation. And those 2 cases, you're not cured of the tumor, you retain the tumor. And so that number adds up in a cross-sectional prevalence. When a patient asks, how common are these? They're not asking you for incidence. They don't understand that usually. That's not the point. They're asking, what's the chance that they would have gotten this just by probability? What's the probability they would have got this over their lifetime? And it turns out, we'll present the data here in a second, but turns out if you live up to the age of 70, 1 in 500 people will get one of these. So it's, it's not 1 in 100,000, which we commonly misquote. And that's an old statistic, and it makes prevalence and incidence. The real answer is 1 in 500 if a patient asks. This is just some data. We have something called the Rochester Epidemiology Project that was conceived in 1966 by a neurologist, which basically captures every single medical encounter in Olmsted County during that time of people in Olmsted County. And so it allows us in a very detailed way to follow rare diseases and things. So this is data from there just to basically support the claims that I just said. The prevalence increases significantly in the older population, but 1 in 2,000 adults, and if you live to the age of 70, there's a 1 in 500 chance that you'll get a vestibular schwannoma. This just shows that over time, in the pre-MRI era, so MRIs really became ubiquitous, particularly with gadolinium use in the 1990s. CT was kind of mid 1980s. And prior to that, there were all these crazy things. They do cysternography, air cysternography, arteriography to find tumors. And you can, as you might imagine, all those were very insensitive. So only big tumors were diagnosed when patients had bad symptoms. So pre-MRI era, big tumors, bad symptoms, more MRIs around, better resolution, smaller tumors. And that's all this shows is today compared to a long time ago, tumors are much smaller. Patients have less symptoms. There's a significant increase in the incidence and prevalence of vestibular schwannomas over time. And naturally, we all think it's just enhanced detection. So we have more MRI scanners available, and people are living longer, and there's more people on Earth. And now you stub your toe and you get a head MRI. It's what happens in today's culture, in today's medical environment. And so everyone's getting these scans. And so, of course, you're detecting more tumors, often incidentally. So most people think that the reason there's more tumors diagnosed now than ever before is because there's more MRIs available. If that were totally true, the rate at which a person gets head scans or the prevalence of head MRIs should parallel the increase in the incidence of vestibular schwannomas diagnosed. And if you plot these over time, you can actually see that maybe enhanced detection doesn't account for all the differences. There may be a small biological shift that's actually even increasing beyond what you'd expect just from having more MRIs. It's not crazy to think that that could be true. There are a lot of things in otolaryngology that have changed over time. Otosclerosis, for example, is well established that the prevalence incidence of otosclerosis has dramatically declined. Another condition that is going in the opposite direction is HPV-associated oropharyngeal carcinoma. So now it's substantially more prevalent than it used to be. And so it's not crazy to maybe believe that vestibular schwannoma is having somewhat of an epidemiological shift. So kind of key points from the first chapter. They're much more common than what people would commonly quote or what you might read in a textbook. It's really 1 in 2,000 adults and 1 in 500 over 70. They're diagnosed at smaller size older patients with fewer symptoms because we have more MRI scanners that are more sensitive. And it's possible we're actually witnessing a true biological shift in the disease. So now we'll talk about the diagnostic process. So how does a patient present? What's the workup? And what's the standard of care for a workup, for example? So the most common symptom that a person presents with the vestibular schwannoma, no surprise, hearing loss and ringing. So the 8th nerve is comprised of 3 divisions: the superior vestibular nerve, the inferior vestibular nerve, and the cochlear nerve. Most of the time, the schwannoma is developing from one of the vestibular nerves. You'll read in some papers, the superior vestibular nerve is more common. Other papers will say the inferior vestibular nerve is more common. I will say that after it gets a little bit larger than 5 millimeters, you can't tell where it comes from very well. And particularly over 1 centimeter, it's almost impossible to tell where it comes from. So I'm very skeptical of all those studies that say we explored the nerve intraoperatively on a 4 centimeter tumor and found out indeed it was coming from the inferior vestibular nerve. That's a bunch of garbage. That doesn't make any sense. On a real small tumor, you can tell, but it's about the same between the two. Just as a general concept, sensory nerves, if you think of the size of a sensory nerve, it's bigger than a motor nerve. You'll see this rule of thumb works pretty well. And the other thing about it is they're weaker than motor nerves. Motor nerves can become weak from manipulation or something like that. And if you treat them early enough, they'll often return function. Sensory nerves aren't as good. They're not as robust. So in the internal auditory canal courses, 4 nerves that do 3 things: one, the facial nerve, the 2 vestibular nerves, and the cochlear nerve. And so hearing loss, 90% of patients with vestibular schwannomas have unilateral hearing loss. So that's the most common. Tinnitus is associated with hearing loss. It's often looked at as the phantom limb syndrome or phantom limb pain, where the brain tries to adjust to injury to the inner ear from having the tumor, and it maladapts and it generates this noise we call tinnitus. Dizziness, vertigo is actually pretty uncommon. Probably less than 5 or 10% of people report vertigo, but momentary dizziness with quick head turn is very common. That term is called oscillopsia. And it's the idea, so there's something called the vestibular ocular reflex. Your eyes and your inner ears have a very fast reflex that go back and forth, and it helps you orient yourself in space. And so if you turn your head quickly and your labyrinthine function, your vestibular function is compromised on one side, your eyes don't adjust to it as quick. And there's this momentary unsteadiness when you turn your head quickly. So you'll hear a lot of patients say that even before treatment, that they have momentary imbalance with quick head turn. Vertigo is uncommon. Just as we talked about earlier, the sensory nerves are weaker than the motor nerves in general in the body. And that's true for the facial nerve. So facial paralysis from a vestibular schwannoma, a treatment-naive vestibular schwannoma, is uncommon. You'll read in the literature, it's between 1% and 5% for, at least in the United States, based on the tumor sizes we're seeing. When they get very, very large, it's more common. But in general, facial nerve paralysis is an uncommon finding with a vestibular schwannoma. And the presence of facial nerve paralysis, particularly with a smaller intermediate-sized tumor, should raise suspicion for something else. Something else could be a facial nerve schwannoma, or a meningioma, or even a malignancy. Metastasis into the internal auditory canal mimicking a vestibular schwannoma is not common, but it's definitely reported on. And then fifth, nerve symptoms. Trigeminal neuralgia is uncommon in a treatment-naive tumor, but trigeminal neuropathy or hyposthesia is quite common, especially after you get over about 2 centimeters. Unilateral facial numbness is pretty common, and most people will say it starts around the mouth and midface, and then it can work its way up in all divisions. Dysgeusia just means abnormal taste. It's not uncommon, actually. And then dry eye is not uncommon. Those two, that sensory and that, and then lacrimation, come through nerves that are coursing through the facial nerve. So your GSPN, your greater superficial petrosal nerve, goes along the Vidian canal and goes and supplies gustatory lacrimation, supplies eye tearing. And the nerve of taste, the chordae tympani nerve, courses along the facial nerve. And so you can see why you can get these symptoms. There's also something called the Hitzelberger sign. It's a commonly tested on thing. It's kind of an old thing, but basically you can get numbness of your conchal bowl and posterior external auditory canal. And because there are small sensory fibers on the facial nerve as well, I'd say that's more trivia, look real good on like Neurosurgery Jeopardy or something like that. Clinically, it doesn't have a lot of relevance. Here's the anatomy. Vestibular schwannomas are benign tumors. They're not malignant. They don't metastasize, and they don't release toxins. They can release proteins, but they're not toxins. So all the effects of a vestibular schwannoma are associated with crowding or pressure on the surrounding nerves. We don't actually know exactly why people get hearing loss with vestibular schwannomas. Everybody would say, well, it's from pressure, pushing on the nerve. That's what causes it. And that would be common. That would make the most sense. But interestingly, tumor size has a poor association with degree of hearing loss. We all see these 2 millimeter tumors and the patient has bad hearing, and we see these giant tumors and they have really good hearing. There's probably a very limited association between tumor size and hearing loss at presentation, which is really remarkable to me. So maybe it's something else. Some people thought maybe the tumor actually invades the cochlear nerve to varying degrees. There are some studies that is more common with NF2, but it's uncommon with sporadic vestibular schwannomas. There's some thought that it causes vascular compression. So some part of the anatomy that's relevant to discuss is the fact that the ICA loop gives off the labyrinthine artery. The labyrinthine artery is basically the primary artery, and some people would say the only artery that supplies the critical blood supply to the inner ear. And so compression, stretch, or vasospasm can result in hearing loss. And just practically speaking, it's not uncommon that we'll do a hearing preservation attempted case where small tumor are trying to save hearing, and we know for certain that we preserve the cochlear nerve and it looks really good. We're all giving ourselves high fives, the ABR and CNAP, the cochlear nerve action potential looks great. We walk away and we're starting to close. Then 10 minutes later, the neuromonitoring team says, we just lost your Bayer, your ABR. That's a vascular event, we think. And Unfortunately, it's not overly uncommon, but it's just to say that maybe vascular compression causes the hearing loss. And then lastly, there's this idea that the inner ear circulates fluid with the CSF space. And if the tumor is blocking the internal auditory canal completely, in some people, that precipitates more hearing loss. And you'll hear people say things like dirty T2 signal or elevated increased flare signal, T2 flare signal in the fundus and the inner ear. It's this idea that you have elevated protein levels secreted by the tumor or as a secondary product of the tumor, meaning it can't circulate the fluid very well. When a tumor gets bigger, and typically in most cases, your tumor has to exceed about 3 centimeters before you start getting into the range of hydrocephalus. It's because you have compression of the fourth ventricle and you block CSF flow through the aqueduct. But you can have, there's communicating and non-communicating hydrocephalus you can get with a vestibular schwannoma. You'll see rare cases where you have a smaller tumor in a patient who develops hydrocephalus. There's a lot of theories behind it. Probably one of the more prominent theories is that there's sludging. The CSF has elevated protein and it doesn't circulate the way it should. But I'm sure that there's probably 5 or 6 other theories as to why that can happen. I think the more you know about anything, the more you realize how much you don't know and how much we just kind of make up and tell people. But I'm kind of going through some of the different ideas that we, at least how we try to explain to ourselves and other people. So this is probably one of the more important points of the talk. When do you get an MRI? The MRI is the gold standard for diagnosis. This is we were fortunate enough to work on the CNS guidelines, a couple of the guidelines papers, and this is one of them that talks about when do you get an MRI? And really, most of it comes down to asymmetrical hearing loss or sudden hearing loss. Asymmetrical hearing loss is not uncommon. Most people with asymmetrical hearing loss don't have a vestibular schwannoma, but there's enough people with a vestibular schwannoma, it's worth getting the MRI. And the punchline is, with sudden sensory neural hearing loss, unilateral, or asymmetrical hearing loss, between 1 and 5% of people will harbor a vestibular schwannoma, and so it's probably worth looking. What's the threshold to call it asymmetrical? You'll see that it's very common to get an audiogram that shows that the left ear is just slightly worse than the right. In fact, I think everybody probably has just the slightest bit of asymmetry in between their ears, but you don't want to get an MRI on everybody. So what's the threshold? Well, it depends what paper you read. If you want to find as many tumors as possible, then you have a low threshold. If you don't want to find them, then you put a higher threshold. But in general, at least one frequency of 15 dB or more, particularly at 3000 hertz, or 2 frequencies of 10 dB that are contiguous, so right next to each other. This is just what that looks like. This is what an audiogram looks like. It's frequency in hertz plotted against decibel hearing level. The lower you get, the louder the sound is. The further to the right you get, the higher pitch the sound is. Blue is your left ear, red is your right ear, and you'll see that they don't overlie each other, they're different. And so the left box is the smallest difference that we would call asymmetrical that you get an MRI. So 10 dB difference in 2 contiguous frequencies. The middle one is the smallest 15 dB difference between ears. And the last one is probably a little bit more typical. Usually it's not like you're looking at one frequency. It's usually more obvious than that, but not always. But technically, those are the triggers for it. What about tinnitus? Well, tinnitus is very common. 10 to 20% of adults have experienced tinnitus. And so we're not just going to get an MRI on everybody. Maybe, and this is controversial, but maybe if it's unilateral tinnitus or one side is clearly louder than the other, it's probably justifiable to get. I think trigeminal neuralgia very much warrants an MRI. And persistent facial hyposthesia, unilateral hyposthesia, I think is also a very good indication to get an MRI. Vestibular symptoms, dizziness, we don't commonly get one unless there's more indicators to get a scan. But the primary thing, I guess, the takeaway from this is if the ears are different, if one ear experiences sudden hearing loss, you should get it. There's this really unfortunate common misconception that if you develop a sudden hearing loss and it spontaneously recovers, then you must not have a vestibular schwannoma and you don't need an MRI. this is more of an otolaryngology topic, but sudden sensorineural hearing loss, about a third of people recover to normal after, a third have partial recovery, and a third don't recover at all, with or without steroids. Steroids improve that just a little bit. But vestibular schwannomas can have experienced sudden, people with vestibular schwannomas can experience sudden hearing loss. And if you look at a person with a vestibular schwannoma over their lifetime, about 10 to 20% of people will have at least one episode of sudden hearing loss. And interestingly, vestibular schwannomas with sudden hearing loss are very steroid responsive and often spontaneously improve also. So you can't just knock at an MRI if somebody has a spontaneous return of hearing. I can't tell you how many people we diagnose with that history that they've had that happen at twice, and you get the MRI and there it is, the vestibular schwannoma. I know that some of this is going to be talked about later, but I have, I think, a unique, at least a somewhat unique take on this, and I'd at least like to present some of the data. They're particularly for skull-based tumors. Most skull-based tumors are benign, and there's I would say the primary tenet of skull-based surgery or skull-based disease management is do not do more harm to the patient than what's expected of the disease to do over the remaining life of the patient. So if the patient has a very slow growing tumor that's probably not going to cause much harm, don't go in there and blitz a bunch of nerves. It's just not reasonable or justifiable. And you can apply that principle to you can apply that principle to meningioma and many other tumors. The same is true. You have to understand what the tumor will naturally do, and you don't want to cause more harm than what you'd expect the tumor to do over a person's lifetime. There's a long time ago, before the MRI era, before the CT era, it was thought that vestibular schwannomas resulted in death if they were left untreated. And it's easy to see why, because only large tumors were diagnosed previously a long time ago. People would have surgery when their tumor was very large, and naturally their outcomes were really poor when you didn't have a microscope or microsurgical techniques. And so the diagnosis of a tumor was an ominous thing. It was associated with mortality. Mortality rates decreased quite a bit over time, and now the mortality rate is very low from a tumor. But now with vestibular schwannomas, having MRI and scanning a lot of people over time, we've seen that not all tumors necessarily grow right away after diagnosis. I just want you to think about this kind of intuitively and not just think about the data, because I think there is some incongruity between how we think about vestibular schwannomas in natural history and what we can arrive at just by thinking about it. So the data and what intuitively makes sense don't really match up. So we'll tell patients that about half of tumors will grow after their diagnosis and half don't grow. The Danish literature would say even less than that. They'd say 12 to 30% of tumors grow, and the remaining don't grow. Nobody is born with a sporadic vestibular schwannoma, so it had to grow to the size it is at diagnosis. So by that, all tumors are growing tumors, at least at some point. We have a lot of emerging data that says that the size of a tumor fluctuates quite a bit. Most of the time, it's a small enough amount where you don't detect it. Our threshold for saying tumor size change is about 2 millimeters on an axial scan, but they do change a lot in size, and they're not just a static object. They'll increase a little bit, decrease a little bit. Their overall trajectory is to increase over time. But if you look at the literature, the Danish data probably is the most robust or the most recent, most heavily cited literature for natural history. And the punchline is about 15 to 30% of them grow. There's this idea that if a tumor is going to grow, it's going to grow early on. And if it doesn't grow by 5 years, it won't grow later. It's another common thing that's said. And then the third thing that people will commonly say is once growth is detected, the tumor will continue to grow. So you might as well treat it at that time because it's never going to be smaller, or the symptoms are never going to be better, and the patient's never going to be younger. So these are three common things that are said, and I don't think that they're accurate. So particularly if you use volumes, volumes are more sensitive for detection of growth and also for rating or for tracking the rate of growth. If you use volumetrics to track them, we did a study where we looked at 361 patients in approximately 1,600 MRI scans, and we followed tumor growth over time. And this is a Kaplan-Meier plot. Whenever you do any outcomes research with vestibular schwannomas, you should be, or almost always, using a Kaplan-Meier plot, a time to event analysis, because so many things change over time. So this is the 3 events that are plotted on this Kaplan-Meier plot are time to treatment, time to linear growth detection, and that's typically a minimum of 2 millimeters of growth, and volumetric growth, which we defined as 20% growth based on the literature precedent. That's a debatable cutoff, but that's what we used. And you can see that over time, if you, at the beginning, if you take everybody you're observing and you follow them over time, about half of them ultimately get some form of treatment by 10 years, at least in our practice. About 70% of them demonstrate linear growth, and over 80% of them demonstrate volumetric growth if you follow them long enough. The other thing I want to point out, so that 1/3 grow is not, I don't think that's probably accurate, at least based on US experience. There's a lot of, we don't have time for it, but there's a lot of reasons why I think there's a difference between some of the international literature and our literature. Some of it has to do with methodology. Some of it has to do with the population they're studying. But secondly, I want to point out that growth does happen after 5 years for many of the patients. And that lastly, the last thing is that once growth is detected, tumor will continue to grow. I have a couple of slides that, sorry, let me get back to that. I have a couple of slides that document changes in growth over time. So this is a spaghetti plot that demonstrates volume over time in a group of tumors. And I just wanted you to see how variable growth is. I think you shouldn't think about vestibular schwannoma growth as static or continuous. I think you should think about it as saltatory, meaning it can start and stop. It might accelerate and decelerate. They can shrink as well. Depending on what literature you'll read, 5 to 15% of vestibular schwannomas shrink, and probably 50 to 70% of them grow if you follow them long enough. So what about hearing? What happens to hearing over time if you just observe your tumor? So not if you don't treat it, but you just observe the tumor. You should probably, I think somebody else in a subsequent lecture is going to talk about the House-Brackman facial nerve grading scale. It's a 1 to 6 scale, it's ordinal scale. This is the AO-HNS hearing classification. It's actually parallels the Gardner-Robertson hearing classification that was developed, I think, in Memphis for neurosurgery. But anyways, they're actually pretty similar. The definition for serviceable hearing, meaning the person can, with or without a hearing aid, if you can hear pretty well, that would be what we call serviceable hearing. And the nice rule of thumb is 50-50. It's super easy to remember. If you have better than 50% word recognition and less hearing loss than 50 dBHL, in most situations, you can use a hearing aid, or maybe you don't even need a hearing aid, but it's functional hearing. Once you get worse than 50 dBHL or worse than 50% word recognition, you typically don't get as much benefit. Even with a hearing aid, it becomes non-useful hearing. Just as an aside, because I think we get this hammered in our head a little bit more than you probably will, just being an ENT. The two deficits a person with unilateral hearing loss always sees, I see hundreds of people, thousands of people with unilateral hearing loss every year. They all say this, they have other things they'll say, but they all commonly say they can't localize sound because you need 2 ears to localize sound. So they can hear their cell phone going off just like anybody else can, but if they don't remember where they put it, they don't know where in the room it is. They can't localize it. And then the second thing they'll say is when they're in a quiet environment, they have zero issues hearing. They can hear just as well as you and I. But if there's any background noise, their ability to hear people deteriorates. Every single patient with non-serviceable hearing in one ear will say that if you ask them. Those are the chief things that bother them. So I think that's a valuable thing to remember. But just remember this benchmark, 50-50. Keep it in your head. It's a good thing to put in your back pocket and use when you're talking to patients. So these Kaplan-Meier plots are time to development of non-serviceable hearing. So that means that everybody, so the 466 patients who are at risk at time 0 started off with serviceable hearing. That means they had class A or class B, or also Gardner-Robertson grade 1 or 2, if you look at the neurosurgery equivalent. And if you follow them over time, you can see how it drops off. Hearing continues to drop off over time. And one really fascinating thing to me is that your hearing will deteriorate even if your tumor doesn't grow, which supports the idea that it's not pressure on the nerve, probably. Or maybe it's very limited growth or something like that. But I think tumor size itself and tumor growth itself do not explain the decline in hearing over time. This is not just an important point for us to understand as clinicians, it's an important point in patient counseling. You'll get a patient who will call you, you're observing a tumor, and they'll call you 6 months after diagnosis, and they'll say, I just had a sudden hearing loss, doctor. I'm very sure my tumor has tripled in size. I'm freaking out right now, something like that. And you have to tell them, it's possible your tumor grew. It's possible it didn't. It's very likely very similar in size. Just to say that those events do not mean the tumor has doubled in size. There's a poor association between tumor size and hearing level over time. I think, to me, that's pretty fascinating. This is a great graph. If you really are interested in vestibular schwannoma and you're seeing a lot of patients later, this is a great slide. You basically can take any patient you have, if they're starting out with good hearing, and you can tell them with pretty good certainty the likelihood of them retaining useful hearing in the affected ear at 1, 3, 5, 7, and 10 years. This is based on a data set, a very large data set. I believe it was a total of about 500 or 600 patients, but it was a model that we developed from a large group of patients. So it's pretty cool. Patients like that. This is just to say that if you develop more precipitous hearing loss early in your timeline after diagnosis, you're more likely to develop non-serviceable hearing. That's no surprise. Intuitively, you could arrive at that same conclusion. The faster the rate of something occurs, the more quick it gets to something. That's all it's saying. It's intuitive, but I guess that's what we do. We write papers to show the obvious sometimes. So key points. If you are observing a tumor, about half of them are treated after 5 years. 60% exhibit linear growth after 5 years. 70% of tumors exhibit volumetric growth after 5 years. Tumors can grow after 5 years, so you don't stop surveillance after 5 years. Some people recommend that. I don't think that's a good idea unless you're on hospice or you're 99. Greater than 40% of tumors demonstrate no subsequent volumetric growth. 40% of the tumors that demonstrate no subsequent volumetric growth after 5 years of continued MRI surveillance. So tumors can start and stop. And your initial PTA and word recognition score are the best predictors of whether or not you retain hearing long term. I don't want to get into this simply because, well, I'll get into a little bit. I don't want to steal everyone else's thunder. You're going to get into some other talks later. I just want to mention a couple things. The best, I guess it's good to hear important concepts several times to retain them better. When you think about the management of a vestibular schwannoma, sporadic vestibular schwannoma, there are so many variables that go into it. In some ways, having a really big tumor is really straightforward because there's only one thing you can do. Most people would say you have to operate to decompress the brainstem. If your tumor is really, really, really tiny, most people will observe it, but most tumors aren't really, really, really tiny and really, really, really big. Most tumors are in the middle, and in the middle is where the gray lies. We don't have any predictors right now of whether or not a tumor is going to grow. We don't have any great predictors so you'll read that there are predictors. I can just tell you, I know with very high certainty that none of them are very good. There's nothing about the tumor on the scan that tells you how long it's been there. It doesn't have rings like a tree to know the seasons on Earth it's been. It doesn't have a different color. It doesn't have cysts or anything like that. There's just nothing about it that can tell you if it's going to grow or not. There's not a good way to tell the orientation of the nerves unless it's really small. There's something called MRI tractography. I'm sure you've heard of it before, but particularly for cranial nerves and facial nerve, Japanese are really good at doing it, but I'll tell you, it's not very good, especially for bigger tumors. Tumor consistency is something we talk about also for deciding if you're going to operate on them. It's actually controversial. Some people say a soft suckable tumor is more favorable. Some people say it's less favorable, but there is some advantage to knowing if it's the consistency of it. You might have an increased T2 signal, might mean it's a little softer, but that's also not very reliable either. They're hard to understand what's going to happen next with the tumor, if it's going to grow or not, and what's going to happen with the hearing. But broadly, if a tumor's over 2.5 centimeters and certainly over 3 centimeters, most people think the only option is surgery. You'll hear some people that argue that, but the majority of the community who treating vestibular schwannomas will agree with that. If it's under 1.5 centimeters, most people in the vestibular schwannoma community, providers, will say radiosurgery, observation, and microsurgery are all reasonable. Once it gets over 1.5 to 2.5, so it's between that zone, most people say observation is not a good option anymore. Usually take observation off the table. So said another way, less than 1.5 centimeters, observation, microsurgery, radiosurgery, 1.5 centimeters to about 2.5. Some people say 3. You have radiosurgery and microsurgery. And over 3 centimeters, you usually recommend surgery alone. And you'll hear varying opinions about that, but I would say that that's what most people believe. This just shows treatment trends over time. More and more, we're watching tumors or doing surveillance over time instead of treating them up front. Again, that's a very controversial topic too. I'm sure some of the other speakers will talk about proactive treatment with the idea that there's no better time than the present to treat a tumor when the hearing is the best it'll ever be and the tumor is the smallest it is and the person's the healthiest. Sometimes you win a home run, but sometimes you take a patient who's nearly asymptomatic and wreck their life too. I mean, you can give a person who didn't have any symptom really bad tinnitus later. It's uncommon, it's hard to predict, but it can happen. You might give a person a facial nerve paralysis who had a small tumor who otherwise would never have had a facial paralysis. So it's not as clean as you hope it would be. But most people are observing small tumors. And then if it demonstrates growth, most people are recommending treatment. And again, the trigger for growth most people use now is 2 millimeters of growth on an axial scan in greatest dimension. We have a couple papers coming out to say that that's probably not a very good trigger. I don't want to get into the weeds of that because it'll take a long time to explain, but it's right now, if it grows more than 2 millimeters, we usually say it's reasonable to treat it. The larger the tumor, the more likely you are to recommend microsurgery. This is an interesting paradox that I think is worth mentioning also. So in our field, we tend to pat ourselves on the back to say we've become more conservative over time. We've realized we don't need to treat all these tumors because not all of them grow, or at least not all of them grow to a clinically significant level right away. But if you take the number of tumors that have been treated per population, so you could call it the incidence of a treatment, we actually haven't become more conservative over time. There's a lot more tumors now diagnosed than ever before. And it's true that a greater proportion of them are allocated to observation. But if you just look at the raw number of tumors per population, we're actually not more conservative. In fact, we're treating more than we have before. And this is this concept here. In the pre-MRI era, there were probably tons of tiny tumors that were never diagnosed because air cysternography, polytomography, angiography, all these crude measures never caught all the smaller tumors. In all of these small tumors, the patients lived out their lives all the better for not knowing they had a tumor, and they died of something else at the age of 80 or 70 or 100. So those patients didn't need the treatment, and they probably were better off for not having the treatment and having all the side effects associated with it. So if you look at the pre-MRI, I love this slide because I think it really encapsulates some interesting evolvements in vestibular schwannoma management. If you look at this slide in the pre-MRI era, almost everybody was treated who had a known tumor, but there were many more people that had tumors that were not known about. If you look at the current era, we're probably detecting more. Well, we know we're detecting more. The incidence has increased 4-fold or 5-fold. There still are clearly some that are not diagnosed, undoubtedly, but we're observing more of them. But if you actually count the number of red dots in both of these, we're not any more conservative overall. It's an interesting paradox, and you have to think about it to understand it, but we're not really as conservative as we might like to say. Let's see, how much time do I have here? I think, well, I could go on forever, but we could stop there. We can have some questions if you'd like. I think I may have raised more confusion than being helpful, but I just want to kind of open your eyes to a lot of the things in the textbooks that you'll read and take as dogma that are completely not correct.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.